Hello, this is David Kettlewell, and welcome to Medical Matters, because life matters. Today's show is so meaningful to me, and I know it will be to you too, because it deals with one of the topics that's most important to all of us, which is suicide prevention. We'll be learning about what steps we can take to help those who might commit suicide, to protect them so that they do not, and also to understand it as best as we can. We'll be back in just a moment. We're talking today about suicide prevention, and our guest is Dr. Eric D. Caine, MD. You are the co-director for the Center for the Study and Prevention of Suicide.
Yes, I am. Good morning.
Yeah. Are people scared to talk about suicide?
Oh, absolutely. Scared, embarrassed. Suicide has a lot of stigma in our society. Clearly, many people are embarrassed or fearful is a fair word. Talk about emotional or mental disorders and emotional concerns and life's turmoil and the sense that there's no hope anymore. So suicide is both a taboo topic for individuals when they're thinking, gee, maybe my life isn't worth living. It's also sometimes a forbidden topic in families where one of their loved ones or kin or grandparents or parents died by suicide.
One point I think is worth making is that if we took the approach, don't ask, don't tell, don't talk about it, to every disease modality that exists in America, you can imagine what a horrible job we do at protecting Americans' health. And I think that one of the main things we want to talk about today is that suicide is almost always the result of depression. Depression is a medical condition which can be treated successfully. So what we're saying is people sometimes make a decision to do something along the lines of suicide when actually they're just kind of responding to a disease modality. Doctor, if you could explain that just a little bit about depression and its role in a decision to commit suicide.
Well, I think I have to be careful or precise and say, when you speak about depression, I actually think about it in two different ways. I think about depression as the diagnosis, the disease modality, and I also think about the distress, being down in the dumps and blue and demoralized. Some people will think about depression as you and I do, the condition that can be treated, for which there are really a whole array of powerful and effective approaches, from talk therapies to medications to family support. There are other people who don't identify their distress that way. Nonetheless, we still have to be able to reach out to them too and be able to get them to realize that when they're having a sense that, you know, there's no future and that things are hopeless in the present, that whether we call it depression or not, there's something we can do about that as well. So there's depression as we might call it, the disease or the condition, and depression is the state of mind. And it's very important that individuals understand that even in the midst of really the deepest, darkest trench, there can be some light.
Don't we all suffer from deep sadness and depression at times in our lives?
Well, again, that's why the distinction is useful. There's no doubt that if you're born, you're going to be sad. There are days in your life which are gloomy and sad and distressing. Not everybody suffers a depressive disorder, though. You know, maybe 1 in 5 over the course of their lifetime. So what it's really important to appreciate about suicide is its depression and a whole bunch of other things. Because obviously most people who are depressed don't end up dying by suicide, thank heavens. So part of what we try to understand is what contributes to depression and what else that leads to death by suicide. And then in some people, what's protective? Even in the face of overwhelming depression and a sense of hopelessness, what keeps them alive? Because there are a lot of people who live. And maybe they can teach us something that we can then carry, if you would, or learn from them to others.
Let's pretend that everybody's seen those little kits that are first aid kits, and they have bandages and solvents, and you can put them in your trunk, and if you ever get in a situation where there's trouble, you can pull it out and help somebody. Give us the first aid kit that we should be carrying in our minds for understanding suicide and trying to help others. What can we do? What should we look for?
Okay, so in this era, and there's been an evolution over time, there are two different kinds of first aid kits. There's the first aid kit for the person who's at the edge of the cliff. They're going to jump. What are we looking for? But there's also a great understanding now, and we'll have to come back to it, that we need a whole array of other approaches, kind of like heart disease, and we can talk about heart disease. It's a very good comparison, that help people before they get to the edge of the cliff.
Let's start before the edge of the cliff, and then we'll get to the cliff.
Either way you want.
Okay.
Okay. Well, you know, if you think about heart disease, and maybe the way I could do this, not that we're here to talk about heart disease today, but in the 1960s, I was young. You were probably just a little kid then, since I'm older than you. In the early 1960s, I remember the great fanfare when they started to build a lot of intensive care units in hospitals. We're going to have all these great things. The local hospital where I grew up, you know, spent $500,000, a lot of money at that time, to build this intensive care unit. And in a few years, they found that they didn't affect the heart disease death rate at all, because most of the people died long before they ever got to the ICU. Most people died in the community outside the hospital. Between the 1950s and maybe a decade ago, suicide prevention was only, let's get the person in the emergency department at the psych hospital. I run a psych hospital. Let's get them there. Or when they're on the inpatient unit, or when they've been discharged, or maybe when they're going downhill, we can recognize those warning signs at the last minute when we still have to. And we can prevent it. But it turns out that most people who die by suicide never come to the emergency department or the hospital, never get recognized, because at the edge of the cliff, they're not holding up some big sign saying, I'm about to kill myself. They do it either suddenly or very quickly, even if they've been thinking about it for a long time, or they do it alone in an isolated way where no one can find them. So, like heart disease now, we're talking about what can you do 20 years, 10 years, 15 years, whatever, before, in the same way they say, change your lifestyle, change your habits, eat healthy, you know, exercise. Well, there are certain things you can do that will, in the long run, have an impact on suicide.
Let's look at those in more detail.
Okay. Substance use is huge. Substance use, you talked about depression, but the gasoline is alcohol and drugs for many parts of the life course.
What kind of drugs?
Well, it depends on different time of life. Among kids, it's, you name it, you got it. You know, it's everything. You know, kids are experimenters. They may be using legal drugs. The biggest drug, of course, is alcohol. And then there are all the other under-the-counter medications, the illicit ones, marijuana and cocaine and methamphetamine and whatever people can get their hands on. And that pattern in the population is really very prevalent between the teenage years and the mid to late 20s. Somewhere in the 20s, the drug of choice seems to transition over in terms of when you look at people who've died by suicide. And between the 20s and the mid-50s, it transitions from, as I say, this multiplicity of things to alcohol.
Is it that the drug use creates the depressed state of mind, or is it the depressed state of mind makes somebody want to take drugs, or a little bit of both?
It's a bit of both. I think we don't really understand, and it's important in this field to say I don't know. I don't know. I mean, I've followed people. We've done what are called psychological autopsies and seeing that people have been drinking for 10 or 15 years. But we really don't know which is the chicken and which is the egg.
Ladies and gentlemen, I got to tell you, in 7 years of doing shows, this is the first individual that's actually said, I don't know. I think that's refreshing, and it's a lot of fun.
Oh, okay.
But, okay, so it's an interesting thing about science, is there isn't an answer to everything.
No. We know that there's a mix here. We know that this is we can take different sorts of examples. Among kids, it's the kid who you see sort of starting to spiral down. He's 13, 14, you know, he becomes isolated. He's 15, 16, he's experimenting on the edges. He isn't out of school yet, but he's disappearing almost in class.
You said isolation, disappearing from the edges,
right.
Behavior change,
right.
Shift in behavior.
Right.
More detail on that.
Yeah, well, you know, the kids who, and we can talk about these different pictures across the life course, the kids who die by suicide are mostly young boys, young men.
For more Medical Matters television shows, go online to medicalmatters.tv.